So good morning and welcome everyone. My name is Claire O'Connor and I, on behalf of the McMaster Department of Medicine, the Program for Faculty Development, it is my privilege and pleasure to welcome you all to the inaugural Quality Improvement and Patient Safety Symposium at McMaster University. We know these are trying times and we're inspired that over 200 of you carved out space in your day to attend this event. This demonstrates our collective dedication to making healthcare better and just how important this work is. We are also thrilled to be welcoming participants from all over the world. Our Quality Improvement and Patient Safety Steering Committee came together over 2 years ago with the goal to deepen the impact of quality improvement and patient safety work at McMaster. We really value the interdisciplinary group we have created here. Our members vary in the type of work they do across our organizations and also their backgrounds. One of our very early objectives was to create an event like this, an event for you, our local QI community, to be a place to showcase QI work through your submissions and also to bring you content from the best and brightest speakers. As we contemplated the theme for this year, it was abundantly clear from the effects of the COVID-19 pandemic that we needed to highlight equity and quality improvement. Equity is one of the 6 domains of quality, but perhaps the least action in quality improvement work. This is why we are delighted to have Dr. Tara Kiron with us today as one of our 2 keynotes. She will help bring a greater awareness and understanding of equity and quality improvement. Dr. Kiron practices family medicine at the St. Michael's Hospital Academic Family Health Team and is the Fidani Chair in Improvement and Innovation and Vice Chair Quality and Innovation in the Department of Family and Community Medicine at U of T. We are very excited to hear about some of the incredible work she's been leading. We are also thrilled to have a second keynote speaker today, Dr. Ed Etchells. As we contemplated who would be on our wish list of guest speakers for a QI symposium, Dr. Etchells was right at the top. He is the Medical Director of Information Services and a staff physician with the Division of General Internal Medicine at Sunnybrook Hospital. Several of us on the planning committee have been lucky to have learned from Dr. Etchells during our time at U of T. And it is both his depth of knowledge and relatable down-to-earth style that we are excited to have him share with you today. In addition, we have many breakout sessions. They are curated for both the new to QI and the experienced practitioner alike. Also, don't forget to check out the posters and abstracts, which can be displayed on our website. They can be found on the main page. You can use this little tiny link here, or you could also scan the QR code. The content displayed here only further highlights the thriving QI community in Southwestern Ontario. And at the end of the day, we'll be announcing the winners in each of the categories. So let's get ready for a day that we hope will excite, challenge, and inspire you. And now I will hand it over to Dr. Seychelle Johanna to go over some housekeeping and to formally open the day with our land acknowledgement.
Thank you, Claire. As we begin our day, we're going to start with our land acknowledgement. So McMaster recognizes and acknowledges that we are located on the traditional territories of the Haudenosaunee and Anishinaabe nations. This territory, covered by the Upper Canada Treaties, is within the lands protected by the Dish with One Spoon Wampum Agreement and is directly adjacent to the Haldeman Treaty Territory. We would now like to welcome Dr. Mark Crowther, Chair of the Department of Medicine at McMaster University, to share some opening remarks.
Thanks, Seychelle, and thanks to the organizers. For those of you who know me, someone that knows me really well because they sent me a script. So I'm actually going to stick to my script. I've been told by Dr. Chan that I am to stick to the script. So welcome, everybody, and good morning. It's my pleasure as the chair of the Department of Medicine at McMaster to be here with you today and to welcome you to the first of these symposia. Quality improvement is an area that McMaster's been interested in for a very long time, starting with small projects many years ago, and really focused particularly in the hospitals on process improvement, now to a multifaceted discipline that includes better quality of care, improved work life for healthcare professionals, and patient-centered and patient-partnered initiatives. Quality improvement is now a required part of our program for all our learners, and I am pleased to see that a lot of those learners actually represented in the abstract and poster submissions that we accepted for this day. In addition, some of you may be aware of the fact that the Department of Medicine is supporting a formal community of practice, one of 6, in quality improvement and patient safety, so that our people who are interested in this in the department can have both the support of the department and also a safe and robust place for teaching, mentoring, and scholarship. This symposium is one of the fruits of the Communities of Practice and probably its preeminent initial product. And thanks so much to the Planning Committee for making this day a reality, and to many of the people who you will hear speak today for really pushing very hard to bring to my attention the importance of developing a real community in quality improvement. The future is bright for QI here at McMaster, and it's my sincere hope that this is the first of many symposia, hopefully not just annually, but more often, that are part of fostering and furthering the QI experience, as well as expertise and depth of experience that we have. So I sincerely hope that you all enjoy the sessions today, and I'll hand it back with that to Dr. Johanna.
Thank you, Mark. It is my pleasure to announce Dr. Tara Kiron. Dr. Kiron is the Fidani Chair in Improvement and Innovation and Vice Chair of Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. Her work seeks to improve the healthcare system to better meet the needs of patients from all walks of life. She practices family medicine at the St. Michael's Hospital Academic Family Health Team, where she leads their quality improvement program. She is an associate professor in the Faculty of Medicine and Institute for Health Policy Management and Evaluation at the University of Toronto. She has held a number of leadership roles over the years, including board chair for her family health team, provincial clinical lead for the Ontario Diabetes Strategy, and primary care physician lead for the Toronto Central Local Health Integration Network. We are incredibly lucky to have her present to us today. And I know you all share my excitement for her insight on this very important domain of quality. Please welcome Dr. Tara Kiron.
Thank you so much, Seychelle. It's wonderful to be here, and I'm really honored to kick off what sounds like an amazing day. I know when I was early in my own quality journey, I would have loved to attend a day like this with the different experts that you have, and I'm really honored to kick it off. I think the topic that we're going to speak of is, of course, very timely. And I should just mention that, I'm very privileged to be bringing a perspective of both a clinician and a researcher. I do have a number of grants and research support that I receive, but all of them from nonprofit organizations, with one exception, Gilead Sciences, for a project that I've done on hepatitis C. But yeah, the topic today is very timely. And I mean, I think when COVID started, there was this saying that, we're all in the same boat. It's going to be a time of immense social solidarity. And instead, soon that saying kind of really shifted, and it became really clear that actually we're not all in the same boat. We're in different boats, weathering the same storm, perhaps. And some of us are on like luxury cruise liners, and others are on little dinghies or rafts, perhaps that are leaking and that are slowly sinking. And I think we've seen this play out time and again with COVID itself, and then even, in the beginnings of the vaccine rollout. And I think as we move forward today, I think it's worth, I'm going to reflect a little bit on COVID, but as well on kind of how the situation is actually not unique to COVID, and how, this idea that we're not all in the same boat has been the case despite our universal health insurance system for decades. And it's something that we have to address. And to address it, we have to, go deeply and start to think, recognize not that just we're in different boats, but why we got to those different boats, and address some of those root causes. I think disparities in care, when we look for them, are really everywhere in healthcare. And I'm giving you an example here from primary care, which is the area that I'm most familiar with. So a few years ago, my colleague Rick Glazer and others published a report from ICES that really looked at the availability of primary care in relationship to need in the province. And unfortunately, they found that the areas with the highest needs were having the lowest levels of care. In fact, there's a 10-fold variation in Ontario around access to team-based care by neighborhoods, but really it's the ones that had the highest needs that often in the north and urban areas that had the lowest access to teams specifically. And so this is just one of many examples in disparities in care. And, Julian Tudor Hart, and back in 1971, coined the term the inverse care law to describe this phenomenon of how access to care is inversely proportional to need in many areas. And his colleagues, I mean, I think these are intellectual descendants of Tudor Hart in Britain, wrote this article a couple of years ago, really talking about the presence of the inverse care law still there. And I think some of their findings and reflections apply to us as well. You know, reminding us that the inverse care law is not a natural law, but it's a result of policies that really restrict access to effective needs-based care. And that it mainly affects patients of low socioeconomic status that have multi-morbidity. And so they've got this mix of physical, psychosocial, and social problems. And they need time, empathy, and a holistic patient-centered approach to care. But they don't have, the resources aren't available to deliver that high need. And unfortunately, then we've got results where healthcare is underachieving in poor areas. And of course, you know, this lack of access to healthcare is just one determinant then of disparities in outcomes. The most striking, you know, arguably the most important outcome is mortality. And I'm going to just show you a couple of slides related to that. So this is a graph from a paper published by Laura Rosella and colleagues. And on the y-axis is mortality, so lower is better. And on the x-axis is time, and you can see females in the red and males in the blue. And what you see over time is is obviously mortality is decreasing, which is great. And what you can also see is that the difference between the mortality rate in men and women is also narrowing. But unfortunately, you know, what we see here in the dashed line is the mortality rate in the highest income quintiles, and the solid line is the mortality rates in the lowest income quintiles. And what we see over this time period, actually, so if you look at the blue solid versus the blue dashed line, you'll see that actually there is a widening disparity in mortality for males and females based on income quintile. And, you know, I think some of the starkest disparities that we see in mortality really relate to our Indigenous populations here in Canada. So, you know, this is a graph from Statistics Canada. On the left, we've got men, and maybe we just focus on that for now. And we see the hashed bar is the total population of Canada. And here we're looking at life expectancy. So life expectancy, higher is better. And we've got the total population of Canada have a life expectancy of 79 years, which is a lot higher than the life expectancy of the three Indigenous populations that are depicted here, and quite a lot higher in particular when you look at Inuit men. So when you compare to the total population of men in Canada, life expectancy of 79 compared to Inuit men at 64, that's a wide disparity in outcomes. A call to action, I think, really, for those of us in this space. So these disparities, of course, in care and outcomes have really been illustrated again in COVID-19. And so this is, you know, I'm based in Toronto, and I'm sharing with you some of the graphs from our city where we see, you know, this is from early on, we see on the left here that these are the Toronto neighborhoods with the highest burden of COVID-19 or up in the Northwest. But they actually coincidentally, or not so coincidentally, you know, they're those same neighborhoods that have the highest gaps in primary care, which is what you can see on the right, that Northwest corner there. And then, unfortunately, we see disparities in outcomes. And again, this is data from Toronto Public Health. And in the green, you see, you know, what proportion different racial groups make up of the city of Toronto. And in the gray, you see their age standardized share of COVID-19 hospitalizations. And you can see that for many racialized communities, the rate of of COVID hospitalizations, or the proportion of racialized people who have COVID-19 hospitalizations is much higher than the proportion of racialized people in the population that we would have expected given their population distribution. And you can see that particularly for people, you know, of Arab, Middle Eastern or West Asian descent, people who are Black, Latin American, South Asian, and Southeast Asian. So much of these disparities that we're seeing in care and outcomes are driven by the social determinants of health, those conditions that really, you know, come from where we live, where we work. And you can see that, you know, it's this great graph that the CMA put together that, you know, healthcare, when we think about our wellness and how us achieving healthcare really contributes maybe about a quarter of how well we are. So much more of how well we are is contributed through our life circumstances and those social determinants, whether it be income, education, or race, or other factors. And, I think when in this quality improvement space, so much of our time has traditionally been really focused on getting that healthcare kind of row, that healthcare bucket right, that we're going to do the best that we can in healthcare to make people the least sick possible, to make them as fulfilling a life as possible. But when in reality, the life part contributes so much more to that wellness than healthcare does. And so if we want to have an impact on wellness, on mortality, on morbidity, we need to start to also think about how we can influence those those factors in that life bucket, those social determinants. And of course, the goal then is to try and achieve health equity, which, I think defined here by the WHO would be ideally everyone should have a fair opportunity to attain their full health potential, and no one should be disadvantaged from achieving this. And of course, there's a difference between equal and equitable. Equal meaning, everyone gets the same, but that doesn't necessarily mean it translates into the same outcomes. Equitable, you're getting the things that you need to achieve the outcomes that you want. Now, that's, I think, a simple interpretation of this image that I'm sure so many of you have seen before. And I will just admit here right now that I went to a one-day workshop with Kiki Ojo, who spent in that workshop, the workshops on health equity, and I was lucky that our team organized it. And Kiki spent like 2.5 hours, I think, unpacking this diagram with us to help us gain some insight. So I'm going to come back again and again to this diagram and hopefully leave you with some of the insights I gleaned from that talk with Kiki. But first, I want to share with you a QI story, a story that really illustrates, I guess, my own journey in trying to address equity in the QI space and what I learned from it. And then I'm going to leave you with some, I think, 6 kind of practical things or 6 ways in which I think as QI practitioners, we can start to address what feels like a really big issue, and it is a big issue, health equity. When I was the QI program director at the St. Michael's Hospital Family Health Team from 2011 to 2018, and one of the first things that we tackled was cancer screening. Now, just to give you some context, I work in a really large team. We have 6 clinics spread over the downtown area. We have about 80 physicians, about 60 other health professionals, many clerical staff on top of that. So it's a very large team. We serve at this time, we serve about 50,000 patients. At the time in 2014 that this graph sort of starts at, we probably had 35,000. So we've really grown over in our patient population. And we serve a very diverse group of patients, everything from, young urban professionals to people who are living homeless, refugees, people struggling with mental health and addictions. We have a large HIV program. So a really big range of folks. So in that context, I was leading some quality improvement work. And one of the things that people wanted to work on, early on was cancer screening. And we launched a multi-pronged initiative to try and understand our screening rates and then improve them. And one of the crux of the initiative really was to do proactive recall. So identify who was overdue and then send them in the beginning a letter, and then later on some combination of letter and phone call. And so we started that out in 2014, and you can see from this graph that actually, our efforts were rewarded. So if we look at something like colorectal cancer, that's on the green line here, our screening rates went from about 60% in 2014 until, a couple of years later, hovering at around 70%. So a nice improvement. But then we took a deeper dive into the data, and this is data from our own practice, and we saw that actually, that wasn't the full story. If we started to look at breakdown of cancer screening rates by income quintile, we could see a real difference. And so again, we'll look at colorectal cancer screening, which is on the very right of the graph. And what you can see on the darkest blue line is the screening rate in the lowest income quintile was 66% compared to the screening rate in the highest income quintile, which is 77%. So more than a 10% difference there. And so this was, I think, a wake-up call for us. It was, we pride ourselves on being an equitable practice, a social justice-oriented practice. People cared really deeply about people with making sure we provide high-quality care to everyone. And so when we saw this kind of data, not just provincially, but in our own practice, it was something that we knew we wanted to do something about. So my colleague, the work I'm going to share with you is done together with my colleague, Aisha Lofters, and she and I led a lot of this work with a big team. And we started off by really kind of doing a deeper dive. So neighborhood income quintile, of course, is a neighborhood level variable. It doesn't really drive down to the individual level. And we wanted to understand, if we look at the individual income level data and other sociodemographic factors, what is it that would that same thing hold true? Are we going to see the same disparities? Are we going to see new ones, other factors we haven't seen? So our practice had been collecting sociodemographic data. And so we were able to do this analysis looking at people who had answered the health equity questions and who were eligible for screening. And what we found is that, indeed, patients who lived below a low income cutoff were much less likely to be screened. So that's the blue bar there, than people above the low income cutoff. And that was statistically significant when we looked at it. And we found a similar kind of finding for housing. We didn't find it for some of the other variables we looked at, like language or race, but those were actually a little bit more problematic to work with as well, because many people, when it came to race, white was predominant, and then there were many other categories, and it was harder to, we didn't have necessarily maybe the numbers to really look at that as carefully as we should have. But this did stand out to us that, yeah, we have an issue with people who are living with a low income are truly having lower cancer screening rates. Why is that? When we reflected back on kind of what we were doing, we realized we were taking sort of this equal approach to everyone in our practice. Everyone was getting the same reminder. They were getting that same letter, regardless if they were a man or a woman, or where they lived, or what language they spoke. And maybe, our tactics and our strategies need to be different, and maybe we needed to actually pour in more resources into people who were living with a lower income. And so we did a little bit of that, but we also decided that we also needed to do was better understand the perspectives of people who were living with a low income, and where they were, what it is that we could be doing differently. And so we launched a qualitative study to better understand this, and we asked individuals through individual interviews, what their barriers were for getting screened, what's stopping them from getting screened, and there are really two themes that arose here. One was fear, and there were different aspects to fear. So fear of being diagnosed with cancer, but also there was a lot of fear related to past trauma. So people who described, so both men and women actually, who described past trauma as reasons, for example, for why they were reluctant to get a pap smear or colorectal cancer screening test. And then, of course, there were competing priorities, which I think at the face of it is really easy to understand. So many of these people had, very pressing needs. They're trying to feed the kids, trying to keep up, trying to keep the roof over their head. And that wasn't, and cancer screening wasn't a priority in the same way those other things were. So we learned a bit about, what their perspectives were around what was stopping them getting screened. And then we did also ask them, what can we do to support them to be screened? And, they talked about the importance of their relationship. They said, phone calls actually would be better than letters. We often we throw those letters in the trash because we think they're junk mail, or we don't check our mail. Who checks their mail these days? They talked about the importance of us framing it as wellness and not cancer screening, because the term cancer screening was kind of maybe off-putting, and whereas wellness was something that they wanted to achieve. And they had questions about being well more generally, even outside of cancer screening, that they wanted answered. They wanted, clear information from us, and they wanted a choice. So they didn't want to be forced to saying we need to get screened. And then interestingly, men and women had sort of different ideas about tone. So I think men really wanted sort of this really firm tone, whereas women were wanted sort of a more warm and friendly tone. And then women were really open and interested in a group session where they could talk about things with other women, whereas men were less interested in that. So we took their feedback. We workshopped it a bit more in some focus groups to really understand, how could we put it into action, some of those recommendations they gave us. And then we did a pilot of group educational sessions that tried to bring together a lot of the things they said. So we provided some food and 3 TTC tokens. We it was pitched around wellness. We had screening offered at the end of the session. So, you could get your pap test done right there. You could get in a cab and go to get your mammogram. You get your FOBT kit. At that time, it was FOBT. So at that time, you could get that kit and right then at the session, but it wouldn't be forced. You could choose to do that. So we built in a lot of those elements. And the first session that we ran was really focused on women and women who were overdue for 2 or 3 screening tests. And so we called, 87 women who were overdue for 2 or 3 screening tests in our practice. And unfortunately, a lot of them we weren't able to reach, and a lot of them declined to attend. And then in the end, 15 did agree to attend, and 8 attended this pilot workshop. And people who attended loved it. So one woman said, at the age of 51, I finally learned where my cervix is. Hurrah! And so we got lots of positive feedback. And most eligible people got their pap test or mammogram, but interestingly, everyone took home an FOBT kit, but none of them returned it, which is, of course, one of the big issues we find with colorectal cancer screening. So, all this to say is that, we did a lot of work to try and understand the issue and address it, but at the end, I wouldn't say we came up with a solution that was really going to, make a dramatic difference in equity. We came up with some important insights. And, it illustrated to us that we still have way more work to do. And, I think when I reflect on this, I've left that we've done a lot of things right. We identified and addressed specifically those people who were left behind, which I think is the right thing to do. We really tried to match resource intensity with patient needs. So, at one point during this evolution of cancer screening recall, we learned that phone calls were more effective at recall than letters, but also more time intensive and costly for our practice. And we focused the phone calls, though, then just on people who were living in a low-income neighborhood. So we tried to match the resource intensity with patient needs. And of course, that pilot group was another way of doing that. And, we partnered with patients to really try and understand their perspectives and co-design a solution. What we weren't doing was I think measuring informed discussion, and that's something that we're on our journey on doing. It was clear, from this and other work that we've done with our trans population that measuring cancer screening rates is really a blunt measure of quality, and what we need to do is be even more refined and understand, who we've had an informed discussion with, because many people say no for good reasons. But I think the area where we went the most wrong is that we conceived of the whole thing as something that we needed to do. We would only really think about the solutions that were actionable within our walls of the family health team. And I think that kept us from doing things that may have had more impact. What some of our patients said is, they really wanted a community-based approach. They wanted to have it like in the lobby or floor of their apartment building, for example. We were worried as a family health team, that if we went in there, we would then have to, also be taking responsibility for screening people who are not our patients, which we could do. But and at the same time, though, there would be many of our patients who lived in other communities outside of the geographic neighborhood where our clinics are based, because we have many people dispersed across Toronto who wouldn't necessarily be able to access that. So the way primary care is structured right now makes it very hard to do population-based, neighborhood-based, community-based outreach and care. But I do think actually if we're going to achieve equity, we do need to move to a system that does that. So there's some structural issues that we really need to address.